Good afternoon, everybody. Welcome to another edition of the AFR EMS Case Studies. My name is Chris Ortiz. I'm the EMS Division Chief for Albuquerque Fire Rescue, and today we're joined by the Medical Director, Dr. Kim Pruitt.
Hi, Chief.
Welcome, Doc. And we're also joined by Lieutenant Jerry Martin from Rescue 14.
Yes, sir.
Awesome.
Glad to be here. Thank you.
Yes, thank you for coming back to talk to us. A very interesting case that we wanted to bring you in today to discuss regarding a placental abruption call that you had when you were on Rescue 14. So let's jump right into it. It sounds like Rescue 14, Engine 14, you all were dispatched to a 24 Delta 4, third trimester hemorrhage. And it sounds like you were the first arriving unit to that call. Talk with us a little bit, as we always do, about some of the things that are going through your mind in preparation for a response to that call.
Yeah, I think I can speak for pretty much most providers, right? When we go to any type of pediatric call, definitely the pressure feels like it raises. And then I think a close second to pediatric emergencies is definitely pregnancy emergencies. Typically you're responding, and you could potentially, when you show up, if your patient is in critical condition, you have two critical patients. You have baby and mom that you have to worry about and make good decisions for. So yeah, that's always a concern. And I always pull up the protocols, talk with my driver, and try to game plan. A lot of times it's if they are in critical condition, it's going to be a rapid type transport, stabilize and go. So we kind of talked a little bit about that.
A lot to think through, because that's a great point about the two patients, like making sure that you know what your plan of action is going to be in terms of care, but also having the right resources on scene. Do I need more rescues? Do I need another ambulance? So great thoughts. So you're now on scene. This particular patient sounds like a 30-year-old female, and she elicited that she was 39 weeks pregnant, G2P1. Talk to us a little bit about what you saw when you first arrived on the call.
It was luckily fairly simple. She was just lying in bed. She had a acute onset of vaginal bleeding. It was bright red. She wasn't complaining too much about pain at the moment when we first got there. But stuff, as I'm walking up to her, I'm looking, is she pale? Is she tracking? Does she look kind of weak, tired? All stuff that we would worry about for shock. Basically, I'm looking for shock signs of shock, any diaphoresis, stuff like that. But yeah, she was just lying there. She just stated she had bleeding for about an hour. She said she went through about three absorbent pads. Usually the absorbent pads hold about 5 to 10 milliliters, so you can kind of guesstimate how much blood loss that has occurred. But I think the biggest thing was just getting a really good history, start asking a bunch of questions, getting some answers to where we can put together our plans of what we're going to do. So some of those would be like, we asked the G2P1 how many times she's been pregnant and how many live births she's had. That's a big factor. Is there any pregnancy complications? Is it just the one child, or is it a multiple gestation? And unfortunately, in this day and age, you have to ask, any drugs, alcohol, any use of anything, which can also lead to pregnancy complications. I just tried to get as good of a history as I could, basically.
Was there anything in her history that kind of led you down a certain path as to what may be causing some of the bleeding, or was it pretty unremarkable?
It was actually pretty unremarkable. Yeah, I was obviously thinking maybe a previa or an abruptio. It sounds like it was going down that route, but yeah, just getting that baseline set and making sure her pressure was good, seeing if she was tachycardic, any signs of shock. Because usually how I talk to my guys, when we get that baseline set, we know, okay, we can stay in third gear, work through what we need to. But if anything is abnormal or that we need to fix right away, we can shift up to a fifth gear and start getting after what we need to.
Yeah, absolutely. Doc, bleeding in pregnancy, we know that sometimes it can be normal and sometimes it's abnormal. What are some of the things that we should look for in terms of bleeding with a pregnant mom?
Especially in a late-term pregnancy, you're spot on. The two things I always think about first and foremost are abruptio placentae or placental abruption, and then placental previa. And so that's where your history questions are going to come in to be extremely important. Has she had prenatal care? Do you know where an ultrasound to show where that placenta is lying? Because if it's a low-lying placenta, I think more likely previa, especially if she's at the stage in pregnancy where she may be starting to dilate and go into labor. But even the questions about the social history, like have you used any drugs lately? We know that cocaine, smoking, stimulant use, any spikes in blood pressure are also very high risks for abruption, and they're important questions. Sometimes they can be a little uncomfortable to ask, but those are very important things to know. But any bleeding, especially late in pregnancy, you do have two patients, and there's one patient that we can't see and can't really assess in the field, and so we have to take that seriously and kind of keep moving, because that life is at risk. That may be their lifeline that's bleeding out.
Definitely. So painting a picture for those watching, it sounds like we had a heart rate of 90. Blood pressure was still looking good, 139/80, satting 97%. Temp was good, 97. Sugar was good. So other vitally stable patient. Talk to us a little bit about how that assessment progressed, what you guys found and what you guys did.
So like I said, my patient was luckily very stable. So we just got our baseline set of vitals. I think 5.5 was still en route, so we did start an IV, just in case we had to do give any fluids or anything like that. And then pretty much kind of, like I was saying, just anticipating what we need to do next. For her, luckily she was able to get up out of bed, walk down the stairs, get on the gurney. That was fine. But stuff I like to think about too, if I have a critical patient, start anticipating how are we going to get them down the stairs to the gurney? Can they move? Because sometimes the abruption could result in a lot of cramping and pain and contractions. So if she wasn't able to walk, okay, do we need a mega mover? How are we going to do this? What do we need to take? Stuff like that. So
Taking us back to paramedic school, Doc, placenta previa and placental abruption, probably the two most common for moms past the 20-week period. What are the differences? What are we looking for?
Yeah, so the simple way that I remember it is abruptio placentae, or placental abruption. That's where the actual placenta is ripping apart from the uterine wall, and you can have a lot of bleeding between those two things. And then that essentially means blood's being cut off to the baby, but it tends to cause a lot of pain. And so AP, abruptio placentae, in my mind, I always remember AP, abdominal pain. Whereas placenta previa, that's when the placenta may be lying a little bit too low, close to the cervix, and as the pregnancy progresses and the uterus stretches or the cervix stretches, it may cause some painless, mostly venous bleeding later in a pregnancy. And so I tend to differentiate the two. One's painful and one's really not. It's difficult to tell by the color of the blood where the origin might be, but both, the most important thing is to just recognize that any bleeding at that later stage in pregnancy could be needs to be taken very serious. Also, with abruptions, sometimes if the abruption is contained a little bit higher, there's not always necessarily bleeding. It may just be pain. If that blood doesn't have necessarily a easy way to get out, you can have a large hemorrhage and not have bleeding. So again, it would mostly likely just be very painful.
And is there anything on our physical exam that we can do to differentiate? So obviously we're relying on mom to be the historian. She's going to tell us if she's having pain or not. Is there anything physically or tangibly that we can do, like touching the patient, to know what we're dealing with?
Of course, assessing for shock is really important, because if mom is sick, that means baby's probably even sicker. So checking, I always like to advocate for actually checking a pulse. You get to feel their skin, feel if they're sweaty, clammy, how fast that pulse is. Is it there? Is it thready? And then really with these largely gravid women, you can gently push on the stomach and ask if it hurts on the gravid belly, and they'll tell you it will be painful and sometimes even rigid depending on the degree of the abruption.
Thankfully, patient was stable, so it sounds like we got her down to the ambulance. Any changes, or was it just a transport pretty much from there to a NICU facility, or how did you guys decide where to go?
Yeah, I think she was getting her care at UNM, but that is a good point. Anytime you have that placental abruptio, a lot of times they will have to induce labor if they're at term, and so it's good to make sure that your hospital you're transporting to is NICU capable, have those facilities for your patient. But yeah, it was pretty straightforward, luckily. A lot of good things to think about. I think after some of these Delta calls or any call in general, it's good to think about if you did have a stable outcome, everything was good patient. Go through your algorithm. Okay, if my patient was critical, this is what we would do. This is how we'd handle it. Whether it's with your crew or just in your own head, just review. I like to do that on the way home from a call or something.
Yeah, very important. It's good to think about because any of these bleeding in pregnancy, that NICU capable decision is very important because there could potentially be that baby could be in a lot of distress and we just can't tell. And so it's safer to assume that and get them to a facility that's got those capabilities for a complicated delivery. This one, she ended up having a healthy baby girl. They were able to induce labor. Interestingly, as I was reading about this, the bleeding, depending how long it's been going, there's a really high risk for continued bleeding for the mother. And so they do everything they can to not do a cesarean section because that's a big surgery. And turns out there's some complication rates with that, with continued bleeding and even DIC with a C-section. So they do try to induce first if they can, and that luckily that was successful for her. And even with a successful induction, she still had a very significant postpartum hemorrhage and needed a couple transfusions, but ended up doing fine. But it's still a dangerous pathology.
Interesting. Great to have that follow-up to kind of understand what happens after the fact, and I'm glad that the patient was able to deliver a healthy baby. I think that's a testament to the early recognition of Rescue 14 and the crew, making sure that mom was vitally stable, doing what they could do on scene, and then ultimately get her to definitive care. So any takeaways from this one, LT, on what you would tell another medic if he encounters it, things to look for, things you saw, any key takeaways?
I think the biggest one for me that I wasn't necessarily aware of before reading about this is not to rely on the amount of blood loss that you can physically see. With the complete separation, like Dr. Pruitt was saying, you could have a pretty significant hemorrhage with no bleeding at all. So just make sure you're treating your patient, looking at your patient, getting a good set of vital signs. I think is the biggest.
Vital signs are vital. Yeah, fantastic. All right. Well, great. I appreciate you taking the time to come and talk to us about the call. It was a great job. Any parting words, Doc?
I have one more just key tip. It wasn't necessarily associated with this case, but one of the leading causes of abruption is actually trauma to the belly in a largely gravid lady. So it's things as simple as like tripping on the stairs or a low-speed MVC. If there's any kind of friction on that abdomen, it's important to think about in trauma patients, especially. The reason I'm bringing this up is if they try to refuse, their vitals are stable, there's no bleeding, and as a low acuity trauma, it's still a really good idea later in pregnancy for them to go get checked for this. And really the only way to diagnose it is ultrasound and fetal monitoring. So I just didn't.
No, that's a great point. And it may be a silly question, so tell me if I'm wrong, but let's just say mom's getting her prenatal care at Presbyterian. We have a low-level MVC. But we have a suspicion. Should that patient go to trauma, or should that patient go to where they're receiving their care that has a NICU?
Usually, I think most hospitals in the system, after 20 weeks, they'll preferentially send you, assuming the vitals are stable, up to L&D triage because they're equipped to do the fetal monitoring and the ultrasounds. Unless there's some, let's say it's a big bad trauma with, other things going on, then of course both considerations could be handled in the trauma bay at UNM, but for the most part, if the vital signs are stable and there's no other physical signs of trauma, they still need to go in and they can do the monitoring and testing in the labor and delivery.
Perfect. Great takeaways. Awesome. Well, thank you both for the time. That's all we have for today for this case, but if you have some interesting cases you want to discuss, feel free to reach out to the EMS division, use the SharePoint tab, and come take the opportunity to talk with us about it. So until the next time, thanks.